Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and this lecture is going to be for the Advanced Pharmacology course. That's one of the three core courses for nurse practitioners, and today we're going to be discussing hypertension medications. So let's begin with a little bit of background. First of all, obviously there's a lot of risk factors, and there's a lot that goes into treating a patient for hypertension at the advanced practice nursing level. Please note, in this lecture, we're only discussing the pharmacology content as relates to the advanced pharmacology courses. We're not going to get into the full treatment of hypertension at the nurse practitioner level. For example, we're not going to get into ordering ECGs and checking their retinas and other things that the nurse practitioner would do. So risk factors, we have age, gender, and family history. And the real reason this is in here is so that I could point out the risk factors that we as nurse practitioners do need to work on our patients with in order to lower their blood pressure as part of their treatment, what we call non-pharmacological interventions or lifestyle modifications. So smoking, probably one of the biggest ones out there, is we always have to make sure that we're addressing smoking if that's an issue. Fortunately, we're down to really low double-digit percentage of the US that still smokes. We got to keep getting that number down. And if our patient has hypertension and smokes, even if they don't have hypertension, we can work on that with our patient. Obesity, obviously diet and exercise, everyone knows that. Excess salt intake, that's going to be another non-pharmacological intervention you're going to incorporate on your patient that has hypertension. Keep in mind, these non-pharmacological interventions are universal, whether they're on medication, whether they're not on medication, whether it's already controlled. We're always, anyone who has that diagnosis of hypertension, we're always going to work on them with non-pharmacological interventions. Reducing caffeine and alcohol, both of those can increase our blood pressure. Obstructive sleep apnea is a cause of hypertension, and obviously diabetes and hyperlipidemia, these are risk factors, and these are things that we want to make sure we control in a patient that we're treating for hypertension. How do we diagnose a patient with hypertension? You may see this even on a pharmacology exam. Again, we're touching a little bit on the general APRN approach to hypertension, but we're going to try and focus on the pharmacology side. Diagnosis, per the guidelines, is that it should be 2 separate office visits that have a reading above normal. Normal for most class purposes, we do have JNC 7 and 8 guidelines. For this lecture, we're going to use the AHA 2017 guidelines, which are probably the most accepted and most utilized guidelines today and what you'd be most likely to see on your boards. And over here, we have anything greater than 130 for the systolic and anything greater than 80 for the diastolic would get you that diagnosis of hypertension. Again, it takes 2 separate office visits where we read that blood pressure before we actually diagnose the patient with it. So when do we start to use this pharmacology? Well, per most guidelines, and we're going to discuss specifically the AHA-ACC guidelines, we begin to treat hypertension pharmacologically when the blood pressure gets over 140 or over 90. That means in our office. Generally speaking, we know that our in-office readings are going to be higher than what they truly are and higher what they would be in home blood pressure monitoring or ambulatory blood pressure monitoring, both of which are outside of our office setting. That's what HBPM and ABPM stand for. But when we have a patient that has in our office 140 over 90, again, that's on 2 visits, that's when we want to go ahead and start doing pharmacological treatment. Hopefully, we are already working on them with them on non-pharmacological treatment. Any patient who does have hypertension, we do want to educate them to take their blood pressure, ideally daily, but on some sort of regular basis. Do be careful that we're not educating patients to take their blood pressure and then they get confused and they think, oh, well, it was normal today, I don't need to take my medication. No, we're just taking their blood pressure for them to monitor it and to give that information to us. They should really, in most cases, not be taking any action based on those readings. If their reading is really high, that doesn't mean double the dose. If they come in at 100 over 60, generally speaking, unless they were told otherwise, unless you tell them otherwise, they should still be instructed to take their medication. In a patient that is newly being started on a hypertension medication, most guidelines say to start to bring the patient back in for follow-up and reassess somewhere around 30 to 90 days. A lot of the time, we're going to be starting the patient on a low-dose medication to minimize side effects. So in that case, we probably want to bring them in definitely within 30 days to go ahead and increase that dose so we can get them up to that therapeutic level. But we also, in general, want to keep an eye on these patients. So we are going to bring them back within 30 to 90 days of starting them on a new medication and most of the time also for adjusting a medication. As an APRN, when you're entering the prescription for these patients, especially if you're doing this in a hospital setting, you're going to have to enter parameters. And we're going to talk a little bit more about that when we get to mechanism of action of each of these drugs. But keep in mind, something like a beta blocker, if you're putting that order in, you have to have a parameter to the nurse who's in the acute care setting in a hospital giving this medication to their patient to withhold it if their heart rate's less than 60, or to withhold it for a systolic less than 90 or a MAP less than 60 or 65. All of that depends on what your approach is to this patient's care or the guidelines of the unit that you're working on. But don't forget, at the APRN level, we do need to enter those parameters, or it comes back on us. If, let's say, someone went and gave a antihypertensive medication like lisinopril, so the nurse went and gave it, even though their blood pressure was 70 over nothing, that comes back on us if we didn't have those parameters in there. Finally, we also have something called resistant hypertension. This is something we would diagnose a patient with. Usually, this is when we have them on 3 full dose medications and we still cannot get their blood pressure under control. In this case, of course, hopefully before it even got to this, you're already ensuring that they have compliance. We're considering white coat syndrome and really getting on them to make sure that we get a good log of what their blood pressures are at home or outside the healthcare setting. And finally, at that case, if we do diagnose them with resistant hypertension, they should be going to a specialist, whether that's a cardiovascular specialist or a nephrology specialist. One of those two would be the most appropriate, depending on what underlying and comorbidities the patient has, to fully address their blood pressure. So what agent are we going to select? Again, this is a big step up from RN level because we're going to make the decision. At the RN level, hopefully we already know there's lots of different blood pressure medications out there, but which one are we going to use? Well, first of all, most patients that are being treated for hypertension actually need more than one medication. For reference, a full dose antihypertensive like lisinopril or amlodipine or hydrochlorothiazide usually can only lower the blood pressure a maximum of 20 millimeters of mercury on the systolic. So if they come in with their blood pressure at 175 over 105, there's no way, there's no single medication that's going to get them down to target. We're going to need multiple medications. Our first line agents, and these are pretty well universally accepted as the first line agents, are going to be the ACE inhibitors, that's like lisinopril or enalapril, captopril. Our ARBs, or our angiotensin receptor blockers, which would be like losartan, valsartan. Our thiazide diuretics, like hydrochlorothiazide, or our calcium channel blockers, specifically the dihydropyridines. We're going to talk about each of these in depth in just a minute. We already said that we may need to put these patients on multiple medications. Sometimes we may be putting them right on multiple medications. If they come in and they're having consistent readings greater than 160, greater than 90, there are guidelines that advocate to immediately start the patient on a combo medication, and we'll get into what the specifics are. Keep in mind, we would very often have preference for those things that come in a single pill, such as lisinopril with hydrochlorothiazide or losartan with hydrochlorothiazide or something like that. While I did specify that these are the 4 universally accepted first-line agents to start a patient on that has hypertension, however, in the case where someone is post an MI, a heart attack, in that case, we may use a beta blocker as part of our treatment, even as a part of our first-line agents. And finally, ACEs and ARBs are considered teratogenic. They cannot be given to patients who are pregnant, trying to become pregnant, and you have to be really cautious giving it to any female of childbearing age. It is ideal, and in most cases, it's considered accepted practice that you would verify that they're not pregnant at the time that you prescribe it, whether that's with a pregnancy test or they're on the period, by asking the patient. And you would want to make sure that they have some plan for preventing long-term pregnancy, such as being on an oral contraceptive, IUD, 100% condom use, something like that. That would be your call in what you would need to be assured that this patient's not going to develop a condition where they're on a teratogenic medication and they're pregnant. So let's jump right into the different classes of drugs that we have. Again, some of this is going to be familiar to you from your RN training, especially if you use bullet point nursing to refresh before you got into your advanced pharmacology course. We do have RN level videos as well. So let's go ahead and start with ACE inhibitors. So ACE inhibitors, this includes lisinopril, captopril, enalapril, and others. Lisinopril is generally the most commonly used one of these for oral long-term management of hypertension. It does have the longest half-life, which is good that we can just dose it once a day. This does come in a combination with multiple other medications, such as hydrochlorothiazide. Now, let's talk a little bit about the mechanism of action. This is something that at the APRN level, you have to really, really understand. So ACE inhibitors inhibit ACE. What's ACE? It's angiotensin converting enzyme. So let's back up a little bit and let's review the renin-angiotensin-aldosterone system, or RAAS, renin-angiotensin-aldosterone system. This system is more or less run by the kidneys, and it has a goal to bring a patient their blood pressure up to a satisfactory level. And in some cases, it overshoots and it goes for even higher blood pressure than we want. The RAS system, when it kicks in, it has two primary effects. The first effect is that it causes vasoconstriction. The second effect is that it causes a release of aldosterone, and that aldosterone makes us hold on to fluid. Now, of these two effects, it has much more of an effect on the vasoconstriction, but it also has an effect on the aldosterone and getting our body to hold on to fluids. So what happens in both of these cases? Well, if I vasoconstrict, I'm going to have higher blood pressure, and if I hold on to fluid, I'm going to have higher blood pressure. So RAS is very effective. The renin-angiotensin-aldosterone system is very effective at increasing our blood pressure. Therefore, blocking that system is a key component in addressing hypertension. So the way ACE inhibitors work is they block ACE. And let's go back and figure out, where does ACE play a role in the renin-angiotensin-aldosterone system? Well, for this system to kick in, the kidneys have to release renin. That renin has to combine with angiotensinogen, which is produced by the liver, and then they convert into angiotensin 1. Now, ACE inhibitors prevent the conversion from angiotensin 1 into angiotensin 2. And angiotensin 2 is what causes all of those effects that we just said, that vasoconstriction and that holding on to aldosterone, or that secretion of aldosterone. So by blocking that from happening, by blocking angiotensin 1 from turning into angiotensin 2, we don't have angiotensin 2, and angiotensin 2 is what would have caused vasoconstriction and increased our blood pressure. But since it doesn't do that, we don't get vasoconstriction, so we don't get an increase in blood pressure, essentially lowering our blood pressure. Same thing with aldosterone. By blocking angiotensin 2 from secreting aldosterone, we do not secrete aldosterone. So instead of holding on to fluid, we get rid of fluid, which helps lower our blood pressure. That's the mechanism of action of how this medication works. Keep in mind, you should also understand how this plays a role physiologically and pathophysiologically. Because if I give a patient an ACE inhibitor, let's think about what it's going to do to my vessels. Well, it's going to decrease afterload. Afterload is the pressure the heart has to pump against. It's how tight are those aortic vessels, specifically the aorta and the descending aorta. How tight is that vessel? Because that's what my afterload is. That's what the heart has to push against. And that becomes really hard in a patient that has high blood pressure. By giving someone an ACE, I am going to lower their afterload, which is going to lower the work of the heart. And that's why you'll see on here, we also give this to patients that are having acute coronary syndrome or an MI, because it has that benefit that it can lower the patient's afterload, which lowers the work of the heart in addition to lowering their blood pressure. We do also use this in patients that have chronic kidney disease. In fact, this is one of the preferred agents in patients that have kidney disease. We also use this in coronary artery disease, heart failure, and for patients that have diabetic nephropathy. It does have a few adverse effects. The most common adverse effect is a cough, and the cough usually would start on a patient within the first few months of them being on treatment. Some books say the first few weeks, some say the first few months. It's pretty well accepted that if a patient's been on this medication for more than 6 months and they develop a cough, it's probably not related to an angiotensin converting enzyme inhibitor. This medication can also cause angioedema. That would usually be a pretty big deal. That would make us switch them to another medication. Obviously, that's swelling of the face. A cough depends on what's going on. Obviously, we don't want our patients to have a cough, but if they say they're okay with it, that would be your call in discussion with the patient, whether you want to keep them on it or whether you want to try switching to a different medication to avoid that adverse effect. We do want to make sure we're monitoring their blood pressure when we're giving this, because obviously, just like any antihypertensive, it can lower your blood pressure. And finally, we're also going to make sure and check their potassium, because this can mess up their potassium levels. Any patient who is on this does need regular monitoring of their kidneys. That would be BUN and creatinine, as well as their potassium. The next drug class we have is actually very similar. It's called ARBs, angiotensin receptor blockers. And let's get straight to the mechanism of action, because it's really short here because we just covered it with ACE inhibitors. ARBs also work by inhibiting the renin-angiotensin-aldosterone system. And by inhibiting the renin-angiotensin-aldosterone system, they get their effects of lowering your blood pressure. They work a tiny bit differently than ACE inhibitors. ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, thereby never having that effect of vasoconstriction and aldosterone secretion. ARBs work a little differently. They allow angiotensin 1 to convert into angiotensin 2, but then they prevent angiotensin 2 from going anywhere. All of the receptors that angiotensin 2 would plug into, they get blocked by an ARB. Other than that, they're really, really similar. They both have the exact same net effects. They both do the same thing to afterload. They both have the same positive impact on the kidneys in terms of helping patients that have chronic kidney disease. All of the indications are the same. They're both teratogenic. A big thing to know here is that a patient cannot be on an ACE and an ARB. ACE is an ARB, since they're both acting on the renin-angiotensin-aldosterone system. It would be, it wouldn't be useful to do that, because you would just be working on the same approach as opposed to taking another approach to their hypertension. And additionally, you'd essentially be overdosing them on too much anti-RAS effects in their body. So let's start again at the beginning. What drugs do we have that are ARBs? We have losartan, valsartan, irbesartan. One of the biggest advantages of ARBs over ACEs is that ARBs have less of an incidence of a cough. Remember, a cough we said is the most common effect of taking lisinopril. ARBs don't really have that. So that's a really big plus. And that's why a lot of providers actually go straight to the ARB instead of an ACE. One important point to note, that ARB is an active ingredient in Entresto, which is sacubitril and valsartan. It's one of the most popular medications for heart failure, and we'll discuss that more in the heart failure lecture. However, do please note that if a patient is on Entresto, they cannot also be on an ARB. And in fact, if they're on Entresto, we need about 36 hours before we can get them on an ARB once they stop taking their Entresto. Other than that, all the rest is the same as an ACE. It's the same indications, same adverse effects, except notice we're missing the cough on here, and the same monitor the kidneys and the potassium. Next, we have our calcium channel blockers. But real quick, since you're still here watching this video and hopefully enjoying it, please go ahead and subscribe to this channel. That's the only way this channel gets any support. Please go ahead and do that to help us continue producing these lectures. So calcium channel blockers are divided into two types, and we're only just going to discuss one of them here. The two types are non-dihydropyridines and dihydropyridines. And the big difference here is they both block calcium channels, but one only blocks calcium channels in the blood vessels, versus the other ones, the non-dihydropyridines, block calcium channels in the blood vessels and in the heart. And that's the big difference. So the drugs that we're talking about, and again, this is the dihydropyridines, would be amlodipine, nifedipine, nicardipine would be another one. And how do these work? Well, we know that calcium has a big role in muscle contraction. And if I contract the muscle, the smooth muscle of, let's say, a blood vessel, what did I do? I constricted it. If I constrict a blood vessel, think of a highway. If I go down to fewer lanes, I constrict it. I'm going to go ahead and I'm going to increase the pressure, just like in a highway. I'm going to increase the traffic by going down to just 2 lanes. Same thing in our blood vessel. If I make it smaller, if I make it less lanes, it's going to become more congested, which means a higher pressure. So this is a calcium channel blocker. We said that calcium is heavily responsible for smooth muscle contraction, which in the case of blood vessels is constriction, which in the case of blood vessels is going to cause our blood pressure to go up. By blocking the calcium channels, we decrease that constriction effect. We decrease that vasoconstriction, and therefore we get some vasodilation. And vasodilation, again, picture like an interstate. If we open up more lanes, if we open the artery or vein up bigger, we're going to go ahead and we're going to get lower pressure, lower traffic. So that's how this has its effect. The big difference, like I said, between the dihydropyridine and the non-dihydropyridine is the non-dihydropyridines, think of it non-selective, because it also works on the heart, not just the vessels, the heart. And by blocking the calcium in the heart, it's going to decrease cardiac output and decrease our heart rate. Those are two effects we're not specifically looking for here with hypertension. So since we have a calcium channel blocker that can target the vessels, which is the problem in hypertension, then I'm going to go ahead and I'm going to prefer those over the ones that are non-selective, the non-dihydropyridines. And if I haven't already said it, that's verapamil and diltiazem. Those are the two non-dihydropyridines. So this goes ahead and helps with giving us a targeted approach. Can we use verapamil and diltiazem for hypertension? Absolutely, but that's not what we're referring to when we say we have first-line agents of calcium channel blockers. We're talking about amlodipine and nifedipine. And again, because this works and in the same net result as the ACE inhibitors in that we block contraction, therefore we end up with dilation. So we end up with a more open vessel. That's where we have lower afterload and easier job for the heart to pump out blood. Calcium channel blockers are also used for angina prevention. In that case, sometimes we're talking about amlodipine and nifedipine. Sometimes in that case, we're talking about verapamil and diltiazem. So just do note that. This medication is recommended in pregnancy by some sources. Some say that we have better ones. So I'm just going to stay out of that debate and just leave it at that, that some sources do say this is a good, and some even say that this is our go-to medication for standard hypertension in patients that may become pregnant. The adverse effects, by far the most common, is edema, peripheral edema. So you wouldn't want to start this on someone who already has peripheral edema, and you would want to educate the patient on that. If they do develop that, we would most likely switch them to a different medication. Lots of other less common effects would be things like flushing, palpitations, fatigue, and things like that. Amlodipine does have a really long half-life. It's over 30 hours. I think 30 to 50 is the range that most texts quote. So that's a long thing, and that's good. That allows us to dose it just once a day. And there is a special note that we should be careful in patients that have perfusion problems, such as heart failure, things like that, when we're giving them amlodipine, and we'll get more into that when we talk about heart failure. The last of our four first-line agents are thiazide diuretics, and a thiazide diuretic would be chlorothiazide or hydrochlorothiazide. The last one that's on here, chlorthalidone, some texts consider this a thiazide-like diuretic. I'm lumping them all together in here, as many books do. But just so you know, if you see a thiazide-like diuretic, that would be talking about chlorthalidone. Most of what we're going to cover here applies to both the thiazide and thiazide-like diuretics. Let's talk about the mechanism of action, because you definitely have to understand that. It inhibits sodium and calcium reabsorption in the distal convoluted tubule. Hopefully, you're already in NP school. You remember that distal convoluted tubule is a part of the nephron, part of the kidneys. And in there, lots of different things happen. But one of the things that happen is the body reabsorbs sodium and chloride. And if the body pulls back in from what was otherwise going to go to the bladder, out to the urine, if the body pulls back in sodium and chloride, guess who follows the sodium and chloride? Water. So by the body pulling back in sodium and chloride, it's also going to pull back in water. And by pulling back in water, it's going to increase our blood pressure. Again, think of a highway. If we have a whole bunch of extra cars getting on, that's going to cause congestion, versus if we have a whole bunch of cars getting off, that's going to lower the congestion. So same thing here. If we give a patient fluid, or if we get the body to hold on to fluid, that is going to increase our blood pressure, versus if we can get rid of fluid by giving them a diuretic, we can lower the pressure. So that's how this works. Because it does work by messing with the effects of the kidneys, it is really important, and with their fluid balance, of course, it's really important to monitor the patient's fluid and electrolyte imbalance. So you want to make sure that you get a CMP when you're reassessing these patients to see how their fluid and electrolyte is. This medication is generally considered safe in pregnancy. I didn't see anywhere that said to avoid this in pregnancy. It does have one unique effect, that it can cause gout attacks, any of the thiazide diuretics, specifically chlorothiazide and hydrochlorothiazide. And then finally, chlorthalidone. The big difference between that one and the two actual thiazide diuretics are that chlorthalidone has a longer action. So hydrochlorothiazide is usually dosed twice daily, can be dosed once daily as well. In fact, actually, it's often dosed once daily, but it can be done twice daily. Chlorthalidone is pretty much always going to be once daily because it has a longer action and because it has, and another note is that it has a stronger potency. So an equivalent dose, 25 milligrams of hydrochlorothiazide versus 25 of chlorthalidone, you are going to get more effect and a stronger effect with the chlorthalidone. Is that good or bad? That depends on your decision on what's going on with your patient. One thing to keep in mind, since this medication does increase their urine output, you may not want them taking it at nighttime. So when you write that prescription, go ahead and write it to take it daily in the morning to avoid them having nocturia where they're having to pee a lot at night. Also keep in mind, this is very common in combo medications with lisinopril, with losartan, and other things. So again, any of those that have a diuretic in it, we really don't want our patient taking that at nighttime. So make sure in your order you take it, you put to take it once daily in the morning. Again, with all of these, remember the same concepts. Remember to put in your parameters. Remember when you're writing a prescription, you need to write how many you're putting it for, the number of pills to be dispensed, any amounts of refills, etc. So now we moved on from our first line agents, and our first alternative agent is going to be beta blockers. We did already mention in the beginning that beta blockers is considered a first line agent in specific situations, such as when a patient's post-MI. What are beta blockers? I'm sure you know this list already: metoprolol, labetalol, esmolol, and there's so many more. The mechanism of action here, really important to understand, is that they block the effects of beta-2. Well, they block the effects of beta-1. Okay, beta-1, that's a typo there, blocks the effects of beta-1. So what does that mean? So beta-1 is responsible for making the heart beat faster, harder, and stronger. By making the heart beat faster, harder, and stronger, these drugs increase our heart rate, increase our blood pressure. If I block that beta-1 effect, if I block that, I'm going to slow down the heart rate, I'm going to lower the blood pressure. Now, the beta blockers are divided into those that are non-selective, cardioselective, and those that are cardioselective with vasodilating effects. You probably didn't have to know this at the RN level, but you definitely need to know it at the APRN level. So let's sort of nitpick here on what each one of these are. Propranolol is the classic non-selective. And what does that mean? That means that not only does it block beta-1, it also blocks a little bit of beta-2. You probably can't name any beta-2 blockers because there's no such thing. Beta-2 is responsible for helping us breathe. Why would we ever want to block that? However, because propranolol is non-selective, it does a little bit of blocking beta-1, which is what we want, but it also does a little bit, much less, of blocking beta-2, which is generally a negative effect. We do still use this. It has specific indications. We also use propranolol specifically sometimes for anxiety, situational anxiety, where patients feel that their body's getting all ramped up because of a situation, because of their anxiety. Let's say they have a big presentation or a big test. So we can use that to block the body from getting itself over stimulated and thereby making the patient anxious. So that's propranolol. That is a non-selective beta blocker. What would be a cardioselective beta blocker? That would be metoprolol. So it's more specific to beta-1. It does not affect beta-2. So because it's more specific to beta-1, I'm going to get the same lower heart rate, I'm going to get the same lower blood pressure, but I'm not going to get that impact on their respiratory system. I'm not going to get that negative pulmonary effect. So this would be a better choice to give to a patient who has asthma or some other lung pathology. Propranolol would almost always not be a good choice in someone that has that lung pathology, but metoprolol would generally be a much better option. Still not perfect, can still be a test question in terms of who would you be really cautious to prescribe this? It would definitely be a patient that has some sort of pulmonary pathology, even on the cardioselective, but cardioselective would be a far better choice than a non-selective. And then finally, we have cardioselective with vasodilating effects. In this case, it's cardioselective that it only affects beta-1, but it also blocks a little bit of alpha-1. Alpha-1, if you remember from your anatomy and physiology, alpha-1 is responsible for vasoconstriction. And by blocking alpha-1, we get vasodilation. So a cardioselective with vasodilating effects, and labetalol would be the classic example of that type of a beta blocker. That one is going to lower your heart rate, lower your blood pressure, but it's actually going to lower your blood pressure even more because it has that effect on the vessels themselves. It doesn't only lower your heart rate, your blood pressure by lowering your heart rate, it lowers your blood pressure by lowering your blood pressure, by vasodilating. Beta blockers are also used for angina prevention, where someone is popping their nitro too often. In terms of their discussion between you and your patient about what is too often, you may want to put them on a preventative angina medication, and beta blockers are generally the first line agent for that. And we'll talk more about that in a separate lecture. Beta blockers are generally considered safe for pregnancy. Some of the literature says that there's better options out there, and we'll get to that in just a minute. But a lot of the time, and in most guidelines, these are still considered safe for pregnancy. Beta blockers, because they lower your heart rate and lower your blood pressure, they do have some side effects. Most commonly, this is when you first start taking it and patients adapt to it, usually within a few days to a few weeks. The adverse effects would be fatigue and bradycardia, hypotension. The fatigue is sometimes a big one, and sometimes we want to tell patients to take this at night when they're starting it, or maybe indefinitely to help with that. But it's not an excuse for the patient to not be able to work out. If they're on a beta blocker, odds are they have a cardiac condition, hypertension, something. They should still be doing diet and exercise. This isn't an excuse, but it is something that you're going to have to educate them that they should build up their tolerance slowly, wait till they adjust to the effects of the medication, and so on. Beta blockers do have a cautionary note that they can mask the signs of hyperglycemia. So you should be really careful in giving this to your diabetic patients. It's not a contraindication. It's just a consideration for you as the nurse practitioner to think about. Also, beta blockers should never be abruptly stopped because, and we're going to learn more about this in other lectures, because they actually help the heart with the heart's work. And when I take that away, the heart suddenly has more work. So because of that, I have to be very careful to taper off of it than as opposed to abruptly stopping it. This does apply to all of our antihypertensive and pretty much all long-term medications and all of pharmacology. However, specifically beta blockers, we make sure we really educate that we do not abruptly stop taking it, and tell your patients to be careful that they don't run out of it. Other alternatives that we have our alpha-1 antagonists, and there's a few drugs in this class, alphazocin, prazosin, doxazocin. These are not first-line agents for hypertension. They are first-line agents for BPH, benign prostatic hyperplasia, and we'll talk about that when we get to men's health. However, they're not first-line agents for hypertension, but they may be used for that. They are acceptable alternatives. They can cause a few effects, erectile dysfunction being one of them, and I actually forgot to mention that with beta blockers can also have that issue of causing erectile dysfunction. Again, if you're giving this to a male patient, please talk to them, advise them of the possible effect, and advise them that you may be able to prescribe them sildenafil, vardenafil, Viagra, Cialis, or something if that's appropriate based on the patient's situation and what they're taking it for. The alpha-1 antagonists, let's talk a little bit about their mechanism of action, because you, of course, have to know that at the APRN level. They work by blocking alpha-1. What does alpha-1 do? Alpha-1 strictly vasoconstricts. That's what it does. It vasoconstricts, and we've been talking about that for a while. By vasoconstricting, we're going to go ahead and we're going to get increased blood pressure. By blocking that, we're going to get a decreased blood pressure. So again, this is also going to decrease our afterload and allow the heart an easier time doing its job. One thing I also forgot to mention with beta blockers is that beta blockers actually lower cardiac output when taken at a full dose. Why? Because the amount of output that a heart does is how much it pumps out and how many times it pumps. Well, if I lower either side of that equation, maybe the other one will come up a little bit, and we'll talk about that in depth when we get to heart failure. But by lowering the heart rate quite a bit, unless the stroke volume dramatically increases, I am going to go ahead and have a reduced cardiac output. So we have to be really careful about giving this in patients that have perfusion problems. We do use beta blockers in heart failure, and we're going to talk about why when we get to heart failure, because that might seem counterintuitive right now. But the answer there is it's a much lower dose, because if we gave a full dose to someone in heart failure who already has a low cardiac output, we would cause real problems. For alpha-1 antagonists, again, this is an alternative agent. And the other side effects that it may have is orthostatic hypotension. So make sure you're educating your patient, especially the first few days. Wait till you get used to it. Don't be jumping out of bed, anything like that. It can cause tachycardia, which is usually reflex tachycardia based on the heart rate or on the blood pressure dropping. And again, because of the low blood pressure and or a high heart rate, it can also cause dizziness. These are not issues that we would make that make us not use this drug. We do use it, but we do have to be cautious that when we're using it, we're making sure that we're monitoring our patients and advising them of these potential effects. The next two drugs we have both work the same. They're both alpha-2 agonists. And what does alpha-2 do? Again, this goes back to the adrenergic receptors. We talked about beta-1 and beta-2. We talked about alpha-1. Alpha-2 is responsible for sort of being a check and balance on the other ones. So alpha-1, beta-1, those make the heart rate go up. Those make the blood pressure go up. Those vasoconstrict. Those put us into all that overdrive in terms of sympathetic stimulation. Alpha-2 is sort of a check on that. Alpha-2 inhibits the neurotransmitter of the sympathetic system, which is norepinephrine. And by inhibiting that, it sort of dials down the sympathetic effects. Well, if we dial down the sympathetic effects, then we get a lower blood pressure. It depends how much deeper you want to get into this medication. There is a whole lot more to know. It does have this effect at the central nervous system level of where it blocks alpha-2 and where it blocks that extra sympathetic stimulation. The two drugs that we're talking about are methyldopa and clonidine. Methyldopa is one of the most commonly used agents that we have for hypertension in pregnancy, which may often be called preeclampsia. And the other drug here is clonidine, almost the exact same mechanism of action. Pretty much for our purposes, we'll say it's the same mechanism of action. And that drug is not only used for hypertension, it's also used for ADHD and for pain. Clonidine is available both short-term and long-term. Very often it is used short-term. Let's say we give a patient a dose, let's say in the ER when they come in for a hypertensive emergency. If they don't have any signs of end organ damage, we give them a dose, get them a few days of something, and get them onto their primary care provider. We don't like to use clonidine a whole lot because we don't want our patients' blood pressure peaking and troughing. We want it to be level. We want to get them whatever combination of drugs is working, whether it's 40 of lisinopril and 25 hydrochlorothiazide, whatever it is, get them on what works and keep them at a perfect blood pressure indefinitely instead of it goes up and then we treat it, it comes down and then it goes up and so on. And all of these drugs, because they all work on sympathetic stimulation, the alpha-1 antagonists work by blocking that vasoconstriction, methyldopa and clonidine work by blocking that sympathetic stimulation. All of these can cause rebound hypertension if you've been taking it for a while and you suddenly stop taking it. Or in the case of clonidine or even methyldopa, if you just get a dose and then when the dose wears off, you may get that rebound hypertension. Hopefully this covered everything that you would need to know in terms of hypertension pharmacology for the APRN Advanced Pharmacology course. If you have any questions, please reach out. Have a great day.